I think still, certainly for young fit patients, FCR for the non-17p is the standard of care that we have trials that we're looking at. So the UK's got a big ibrutinib, Rituximab versus FCR trial, similar trial in the ECOG with the ECOG group. So, but those trials are recruiting at the moment. So we're some time before we'll have solid evidence, particularly given the very good outcomes with FCR. So that's the standard of care. In the elderly patients, Obinutuzumab, Chlorambucil, Obinutuzumab, Bendamustine are starting to be used, and we're seeing reasonably durable remissions, but people are relapsing. I mean, ibrutinib now has been available and licensed for a period of time, and we're seeing, of course, continuing good responses, generally well tolerated with ibrutinib. There's data at this meeting and in the last couple of conferences to show that the earlier we use the drug, the better. So if we use it, after 1 or 2 relapses, patients do better than after the 3rd or 4th relapse. And we have frontline data, which is now led to a license in the States and will be is licensed in Europe now as well. So we know compared to Chlorambucil, the outcomes in frontline are astonishingly good, but we're controlling the disease with ibrutinib. There's a small group of patients who don't tolerate ibrutinib, probably 10–20%, depending on the severity of the side effects. And we have new agents coming along, so Acalabrutinib, and there's been at this meeting, the treatment-naive cohort in the phase 1 trial, which looks very impressive, but the follow-up's very short. So there are now randomized trials of Acalabrutinib against Chlorambucil, Obinutuzumab, with Acalabrutinib as well, and then relapse against ibrutinib. So we're really evolving the BTK inhibition. We're struggling a bit with the PI3 kinase idelalisib toxicity. We had a major problem with some of the trials earlier on this year in terms of infections and the autoimmune complications. And I think the dust's still settling in that side of things. And then Venetoclax is, in the last 6 months, the conference at ASH and then this meeting, we're seeing some very impressive results. I mean, in terms of single agent therapy, getting to MRD eradication, combinations with chemotherapy, and we're now starting the trials combining BTK inhibition with Venetoclax, which is a very logical approach. So Venetoclax has now been approved in America and is going through the process in Europe, so hopefully will be more widely available. So we've got a lot of really exciting developments, I think, which, as I said before, promise to move towards a more definitive treatment, even curative treatment for CLL.